as we get older, and they include things like dry eye, and especially here in Southern California, things generally tend to be dry, and that only contributes to dry eye syndrome, which can be quite irritating and disabling in some cases. Cataract is another thing that's more common as we get older. That at least is something we can contend with in modern days with cataract surgery. Glaucoma. Glaucoma is a condition that affects
Unmuting.
The optic nerve.
What's going on right behind this, but I can't get rid of this.
So
Show conversation.
Everyone can stay on mute for just until we're through the presentation. That would be great. Thank you. Also with regards to glaucoma, it's a condition that affects the optic nerve. Again, the conduit that takes information from our eyes back to our brain. And macular degeneration, of course, is probably the most common problem that can affect our eyes as we get older in terms of problems that really cause significant vision loss, and that's why we really want to.
There's no sound. Recording has started.
As I said, to understand macular degeneration, you really have to understand a little bit about how the eye works. That little video at the beginning I showed kind of made the analogy between the eye and a camera. So you have your front part of the eye with your cornea and your lens, which allows you to focus information onto the film, which is the retina. But when we're talking about macular degeneration, we're talking about even a more specialized part of this film back there of the retina. The macula is the very center part, just this very tiny area actually of the retina. But it's a very tiny but very important part of the retina because it contains our most, it's most critical for our central vision, or sort of our straight ahead vision. It's also the part of the retina that's the highest resolution. So if you think again of the retina like a camera film or a camera sensor with our digital cameras now, it's kind of like the 50 megapixel camera versus our peripheral retina, which is kind of like a 1 megapixel camera. That's why our central retina, our macula, is so important, because to really see fine detail and sharpness, you really need the macula. I also want to mention, sometimes, when I talk about this retina being like the film of a camera, it really is thin like the film of a camera. But keep in mind that even though it's thin, so it's only about 1/3 of a millimeter thick, the retina, it's quite thin, but even though it's thin, it itself is very complicated. So this schematic here is showing the organization. All these little structures here are cells in the retina, and so there's a whole layers and layers upon cells in the retina. This tiny 1/3 of a millimeter thick structure, and it's really remarkable in terms of how this all works, because basically light passes through the retina. This is sort of the layers of cells in the retina in this little cartoon, but the light comes from this direction into our eye, and then actually has to pass through the retina all the way to the very bottom of the retina, where we have the special cells. We call them rods and cones. These are the or photoreceptors. These rods and cones, which are two types of photoreceptor cells, they receive the light information that's coming into the retina. Then they turn it into electrical and chemical signals that then are transmitted through the optic nerve back to our brain. So that's how vision happens. And it really is quite an amazing process. It's amazing how these cells can work together to allow us to actually get something back to our brain so that we can understand as vision. And so when we talk about macular degeneration, it's especially these light-sensitive cells, these rods and cones that we use for our daytime vision, for color vision, and the rods that we use in general for our night vision and our peripheral vision. These are the cells that are affected early on in macular degeneration. So let's talk about macular degeneration. And again, I think the semantics and the wording is very important, because there are a number of different diseases that can affect the macula, that very specialized central part of the retina. It's not just this type of macular degeneration we're going to talk about today. There are, people can be really nearsighted, and that can cause a type of macular degeneration. And so I just wanted to be clear that the type of condition we're talking about today, this really common problem, is age-related macular degeneration, or you'll hear us abbreviated AMD. And so AMD is what I'm going to really focus on today. All right, so there's some basic facts you need to know. So this is the leading cause of irreversible blindness in older individuals, and actually just in individuals in general in the U.S., it is the leading cause of irreversible blindness. Now, I will say that things like cataract are more common, but generally we take cataracts out way before someone becomes blind. Plus, it's not irreversible. So macular degeneration is a much more challenging problem. It's also very common. Over the age of 65, at least 30% of individuals will have some evidence of macular degeneration. So this is an important problem. It's also more common in women. And part of it is because women live longer, but it's not just that. There seem to be other aspects for why it appears to be more common in women. As I said, macular degeneration, as the name would imply, affects the macula. Now, we have come to learn, I will tell you, in the last few years, the interesting thing is it doesn't necessarily affect just the macula. We just haven't bothered to change the name for the condition because it probably affects more than the macula, but it certainly affects the macula most severely. So as I said, the macula is that very highly sensitive, high resolution part of the retina for our central vision that is vital for reading, for driving, for watching television, all the things that we love to do. But your peripheral vision is largely spared. Now, it's not completely spared because macular degeneration can have some impact on the peripheral retina. It can affect the rods, which we use for our night vision. And so one of the first things I'll see many of my patients with macular degeneration tell me about is they say, yeah, you know, my vision at nighttime is just not as good. And I really need a lot of light. And part of the problem is related to the fact that it's not just a central macular problem or a central problem, but it is the part of the retina that's affected most severely in macular degeneration. And so because the central vision is what's affected most severely, blurriness of central vision is one of the first things people might notice. Also, one might notice distortion or waviness of lines. So many of you, I know some of you who are on this meeting today have macular degeneration, and you may have been given this type of a grid test by your ophthalmologist. I'll talk about it a bit later, but it's a nice way of picking up whether straight lines are becoming wavy. So it's a nice way of detecting macular degeneration, hopefully early on. Okay, so let's say that you go to your eye doctor's office and they diagnose you and tell you that unfortunately you have macular degeneration. Well, how did they make the diagnosis? What are they seeing? And so one of the key features that your eye doctor is looking for when you come to see them to make the diagnosis is something we call DRUSEN. Now, I haven't shown you a lot of pictures of the retina yet. This is a picture of the central part of the retina, the macula again, and it has this kind of like appearance with these red lines being the retinal blood vessels that are in the retina back there. And this is the optic nerve that's off to the side there, but this very center is the macula. You don't have to be an ophthalmologist or a retina expert to see that this image looks very different. Okay, this is from someone who has macular degeneration, and you can see very apparently that there's all this yellowish stuff there, and that's these DRUSEN. That's these DRUSEN deposits. They sort of build up underneath the retina, okay, down here below the retina, and these DRUSEN deposits, you kind of think of them as sort of trash building up in the eye. Normally, these kinds of things are cleared away by the cells in our eye. We call a special kind of cell, not so important for this presentation. You don't have to remember all the stuff, but we call a special cell called the retinal pigment epithelium, or RPE cell, that really is actually one of the most, actually it is the most active cell in our entire body, but it's responsible for keeping this area clean. And that's one of the things that stops working as well as we're getting older. And so things start to pile up, and these DRUSEN deposits accumulate. Okay, and that's how that's one of the main ways your doctor makes the diagnosis early on. And so then a question often comes up. I will tell you, I get a lot of referrals for patients who come in really worried that they have macular degeneration because they've seen someone who's recognized that they have DRUSEN. And so the question then comes like, my doctor said I had DRUSEN. Does this mean I have macular degeneration? Because I just got to telling you that that's an important way that we make the diagnosis. And so here's another picture. Again, I don't know if I'm going to make you retina experts by the end of this presentation, but I think there's already some things you could pick up on. You can look at this eye and say, wait, there's these little tiny little dots here. maybe those are drusen. They are drusen, actually, in fact, but these aren't the kind of drusen we're talking about. This is not macular degeneration, but I often get people who are sent in because someone has spotted these little guys and say, oh, aha, drusen, you must have macular degeneration. And that's because these drusen are really, I can go back for a second here, are really, really tiny. Okay, so if you're wondering like how tiny an area we're looking at, this is all really blown up stuff. These kind of pictures of the retina I'm showing you. Just to give you an idea, here's a vein, and this vein here is about 1/8 of a millimeter in width. So imagine how tiny these guys are. These are like 1/16 of a millimeter in their diameter. So they're really super tiny. And drusen that are this tiny, we know we don't really worry about it very much. And that's because this is a graph showing from a very important study the National Institutes of Health did, where they looked at people who had just these tiny drusen, and they compared them to people who had no drusen at all. And basically, there was almost no difference in terms of your risk. This is your risk for developing advanced macular degeneration. You can see after 10 years, there's almost no difference. And so the reality is that more than 90% of people over 65 will have at least some of these little guys, these little small drusen. And so just because somebody tells you have drusen doesn't mean that you have macular degeneration. It really matters how big the drusen are. In fact, we actually had this effort that I was involved with, which are some of the major experts in the world on macular degeneration, tried to sort of highlight the difference between aging and macular degeneration. And actually we said, maybe we should stop calling these little tiny drusen because it's making everyone confused. They're worried they have macular degeneration. We suggested a new term called druplets, which I guess no one liked because no one calls them that now. But we had suggested, and really to highlight that, because I really want to bring that point out, because as I said, I get so many people who come in asking me, do I have macular degeneration? Because somebody said I had drusen, and it's important that it's really only when you have bigger drusen, like these guys. Look how big these drusen are in this eye. These bigger drusen are what we are worried about. The trash and these kind of materials are building up and may make someone susceptible to losing vision from macular degeneration. Now, another terminology that many of you may have heard is dry macular degeneration versus wet macular degeneration. And sometimes people will come in and ask me, well, oh, is it good to have one versus the other? And it's actually kind of complicated. There's not a simple answer to that. So I want to explain a little bit about dry versus wet macular degeneration. So first, we have to understand, well, what is wet macular degeneration? So what happens in wet macular degeneration is these deposits. And again, this is sometimes I'm showing you pictures where you're looking into the eye, and that's what the doctor kind of sees. And sometimes I'm showing you pictures like this, which are, if you turn the retina on, rather than looking at it, you turn it on end, so you can see the layers of the retina. It's easier to tell where the deposits and abnormalities are. So as I said, these drusen deposits accumulate underneath the retina. And when these deposits accumulate there, they can sometimes weaken the tissues under the retina, and then cracks can form that allow the blood vessels that normally would provide nutrition to the retina, they can sneak through this barrier, and they can actually get right up into the retinal cells, and they can start to leak and bleed. And these new vessels, we call it neovascularization. These new vessels, as you can imagine, can actually cause a lot of problems when they can bleed like this, and they can directly damage the cells. And so that's what we call as wet macular degeneration, when these vessels have grown in directly underneath the retina. And so if they're left untreated, they continue to kind of wreak havoc back there. And again, you don't have to be a retina expert to imagine that having a big blob of blood like this, not good for your vision. And if it stays there and is untreated, eventually it can cause a big scar. And so this whitish sort of thing that you see in the macula of this poor individual's eye is unfortunately damaged their vision quite severely. It's a scar that's left with loss of vision. So this is one of the reasons why someone with macular degeneration can go on to lose a lot of vision. So again, those areas of the retina are damaged. All right, so you can imagine that, maybe it'd be important to tell whether the macular degeneration has turned wet, whether it's developed these new blood vessels early on, because maybe something can be done to treat it. I'll talk about that in a moment. And that is true. We do want you to be able to detect that early on. So that's why we give you these things like the grid test. I don't think you necessarily have to have this grid test. We call it an AMSA grid. You can even just look at anything with straight lines, like, you know, the corner of a door. You're just looking for things that might help you pick up on waviness that you might not have otherwise noticed. The most important thing is covering one eye at a time when you do this type of testing. And you can imagine if there is like serum that's leaked out from the blood vessels, that can kind of distort the shape of the retina, and that's what causes this type of distortion to appear. So how does your doctor tell whether your macular degeneration has turned wet? Well, obviously, if they look in and they see a big blob of blood there, they can probably guess that it's probably turned wet, but we can get other types of tests. So I was showing you, as I said, I was alternating between pictures of if you looked straight on at someone and looked right into their eye, into their retina, you would see this appearance. But if you turned it on edge and looked at the layers of the film or the retina, you would see this kind of appearance. And we actually have amazing tools that your eye doctor has now. One of them is called OCT. And OCT allows you to see the layers. Again, like, you know, the layers of the retina itself. This area is only about 1/3 of a millimeter. This is much thicker than 1/3 of a millimeter. This is more like almost 1.5 millimeters, and that's because of all this blood that's developed underneath the retina, because these blood vessels have grown in and they've leaked and bled, and you can see how they can distort the retina. See that? So that's how the retina can be distorted. And you can imagine when your eye doctor sees this, they have a pretty good idea that you probably have developed wet macular degeneration. Sometimes, though, it's not so obvious. You can't be sure just looking at that picture. And so another test that your eye doctor may do is something we call a fluorescein angiogram, where we inject some vegetable dye into the arm, and then we take pictures of the eye. So these are the kind of devices we use to take pictures of the eye. We call them fundus cameras. Fundus is another word for the retina. But you can see this looks very different from any camera you might operate at home. But it's not so different. It just has some special lenses and things here that allow you to essentially function like a microscope. So it's kind of like a microscope attached to a traditional camera is really all that is. But if you take the pictures after the dye is injected, this dye is fluorescent. And so then it allows us to see the flow that's happening with blood vessels. It's actually a pretty safe dye. It was actually used in the old days when they used to turn the Chicago River green on St. Patrick's Day. This is what they put in the water. So it's a pretty potent dye, but it's actually something that allows us, because of its fluorescence, to take pictures of the vessels in greater detail, and then you can identify new blood vessels that may have developed, so that because the dye will leak out of those blood vessels. So again, I'm not teaching you how to be a retina expert, but I will tell you that you don't have to be too much of an expert to see there's something wrong here. And these are the new blood vessels that have appeared and have started to leak because of the wet macular degeneration. Nowadays, we have an even greater advance. So if some doctors might have this, we certainly have this in our offices at Doheny. We're certainly been very involved in the cutting edge of this research in new technologies like this, which is called an OCT angiogram. So you don't have to get a dye injection anymore, but we can still tell whether there are blood vessels that have grown in. And it's a great way for us to be able to diagnose wet macular degeneration when it's early on, before there's been a lot of bleeding and other things that have happened. Okay, so one thing I haven't explained so far, which is a common question, is, well, okay, you've told me about the difference between dry and wet, or at least I've told you how wet macular degeneration can affect your vision. Well, why does it happen? I mean, why do we get wet macular degeneration? And so our current concept of how we think about wet macular degeneration is that we don't necessarily think of wet macular degeneration itself as being a bad thing. When it's left to its own devices and it bleeds and the like, yeah, it's obviously bad. But fundamentally, our eye is pretty smart. Our body's pretty smart. When it sees that it's struggling, maybe because of age, that we're starting to accumulate this trash, this drusen deposits, it knows the retina is struggling. And so it brings in these new vessels as a last-ditch effort to try to bring more nutrition to the cells and try to save the cells. So it's a good idea, but it's poorly executed because these new vessels are fragile and they can bleed. And so when I talk later about how we treat this condition, this wet macular degeneration, in the old days when we were treating this, we would think about, let's get rid of all these vessels, let's make them go away. But now we think about, you know, the vessels actually could be doing something positive. We just have to keep them from bleeding and wreaking havoc. We need to keep them controlled. So just something to think about, a new concept that's come up in our thinking about macular degeneration that your doctors may talk to you about when you come to see them now. In any event, we don't want to let these vessels get out of hand because they can bleed, they can cause a lot of damage right away, and so we want to be able to treat them. Now, I have to tell you, when I did my residency, it was over 20 years ago now, and we didn't have any way of treating macular degeneration when I was a resident, and so it's been pretty exciting over the last 15 years that we actually have options. And we have the ability to inject medications into the eye. For some of you who maybe on this call have had eye injections, those of you who have not are probably feeling pretty squeamish right now about the thought of somebody putting a needle into your eye, and we go into the white part of the eye to do these injections of medication into the eye, which can then travel back to the retina. But it's not as bad as you're thinking, because we numb everything up and the like, and it's over in a flash. But in any event, these medications can be quite capable. They can certainly stabilize the vision and improve it in many cases by stopping the vessels from leaking and wreaking havoc. Doesn't necessarily eliminate the vessels, but stops them from leaking and causing problems and damage as a result. But unfortunately, there's always, with the good, there's some bad. In that these injections, unfortunately, they don't last. The medication goes in, but it kind of gets eaten up by the body over time, and you have to keep doing the injections. And sometimes they have to be given as often as monthly, which, if you're already not liking the thought of an injection, you're probably liking the thought of an injection every month, even less. And then there's even an ugly part of this in that, unfortunately, as I said, when I said, I don't automatically say wet macular degeneration is worse than dry. It really depends on what stage the dry is, because just because you may have treated the vessels, it doesn't mean the macular degeneration overall isn't progressing. And in fact, it can continue to progress. And so you could still, unfortunately, lose vision even if the blood vessels are treated from the macular degeneration. So that's something that is still a big challenge. So some of you who may be getting these eye injections may be wondering, gosh, how long is this going to go? Am I going to be able to not keep getting these injections, or at least go much longer between injections? And there are newer advances that you should be aware of. In fact, we just had a major meeting of our field a few days ago where we saw for the first time the results of the late stage clinical trials for something that you'll hear a lot more about called the Port Delivery System, or PDS. It's a refillable device. Actually, the origins of it start at Doheny when our former colleague Jean Dewan was here and had been working on this technology. But in any event, it's now finally out in the real world, and essentially, it's not available yet. It's not FDA cleared yet, but hopefully will be soon. But basically, through a minor procedure, the eye doctor can put in one of these ports. And then you can just refill the port, and then the port can deliver the medication for 6, 12 months even, and you don't have to keep coming in for eye injections. This is what it looks like. Obviously it'd be hidden by your eyelid. This is with someone looking down, that you can kind of see what it looks like there, that port. But that's a new technology, and there's a whole host of other things coming, drugs that last even longer in the eye, even without using a port, and even gene therapy. And so there are a whole host of advances that hopefully will make it a little bit more easy, or at least you're not coming to get injections all the time for this problem. Now, as I mentioned, it doesn't mean that you've cured macular degeneration by any means. You just controlled the vessels, and not everyone develops wet macular degeneration. Some people, you have DRUSEN, and then eventually you wait several years and you just start to lose the cells. Now, without being a retina expert, it might be hard to tell the difference between these pictures on the left and these on the right. It's the same individual, but 7 years later. But you might be able to see how discrete these areas are, which are areas of missing cells we call atrophy. And you can imagine, this is just another example to compare a normal retina or macula with one that has atrophy. Again, I don't expect you, not being a retina expert, to be able to tell that that's atrophy, but I do expect, actually, with this presentation, you can tell when something's not normal compared to normal, and this is an area of a patch of missing cells. So you can imagine if you're missing light-sensitive cells right in the center, in the highest resolution part of the camera, you can imagine why that could be pretty impactful in terms of our ability to see. And in fact, you can have blurry or blank spots in the vision. Usually people just say it's blurred out there. I just can't see any detail in that area. And that's when we talk about the kinds of things that we rely on centers like the Braille Institute to help us in coming up with strategies when our sharpest vision in the very center has been lost from problems like macular degeneration. So the end stage of macular degeneration is this atrophy. It's a loss of the light-sensitive cells, and it can occur with dry macular degeneration with someone who's never developed new blood vessels. But I wanted to emphasize that, unfortunately, it can occur if you've got wet macular degeneration that's been treated. It can be successfully treated. So sometimes you say, well, what do you mean, doctor? You said that macular degeneration is successfully treated. I can't see. And it's a very good point that you're making if you say that. The doctor is talking about he's controlled the vessels, but he hasn't stopped the degenerative process. And that's why, a lot of times patients come in to see me and they say, tell me, do I have wet or dry? And we don't really think about the disease quite like that now. We think about macular degeneration as a disease that starts with these medium drusen and ultimately progresses to atrophy. And, the new blood vessels, this neovascularization or wet macular degeneration can happen in some patients, not in everyone. Maybe some patients' eyes don't even try to save the retinal cells. And in the past, when I was training, it just caused a scar and you lose vision right away. Now we can treat it with these new injections, but it doesn't stop the fact that our eyes and unfortunately our whole bodies, I guess, over time are degenerating or aging. And so atrophy is still the big problem. So at this point, you might be asking, well, okay, I get it. Atrophy is the big problem. Well, why haven't you cured it yet? Get busy and get this solved. And the reason is it's a hard problem. Because in some ways, I sometimes say, well, once we cure aging, I'm pretty sure we'll cure macular degeneration atrophy. And it's hard to stop things that are degenerative from aging, but it doesn't mean that we can't. And actually, one of my predecessors, Doheny Steve Ryan, who's the president of our institution for many years, he started this great effort called which used to be called the Beckman Initiative. Now it's called the Ryan Initiative for Macular Research, which really tries to get people, experts from around the world, to come and meet together, bring their expertise, and really think. It's almost like a giant think tank, and even bringing experts who are outside the field, because sometimes you need to have experts who are not in the field to help you make breakthroughs or solve problems. Like you bring in chemists, physicists. They may not have a clue about ophthalmology. We teach them a little bit about what our problems are, and they can weigh in from their field's perspective and help us make these kinds of breakthroughs. And it really has taken us a long ways. I just wanted to credit actually a couple of people I work with. I'm very proud to work with these sort of people like Dr. Alfredo Sadoun, who has done a lot of work in helping us understand why our eyes age, right? Because as I said, in part, it's a curing an aging problem, maybe a premature aging problem of our eyes. And a big part of why our eyes age is actually an issue of energy. And so there's these little tiny structures inside. This is a cell. This is one cell of obviously trillions of cells in our human body. And these cells, they're powered. Obviously right now we have huge power problems in Texas because of the ice storms. Well, our bodies are powered by these little guys called mitochondria. They're the energy factories in our cells, and they seem to be what are really becoming less and less efficient as we get older in terms of producing energy to keep our cells going. And so that is a key part of why we age. And so now a lot of us are focusing our attention on how do we target that. Ram Kannan has made some huge headway at Doheny in his laboratory on identifying small molecules that can protect these mitochondria and help them work better. And so you'll hear a lot more about this in the future as we think about new treatment approaches for macular degeneration. These kinds of neuroprotectants or strategies that protect the cells from aging and enhance their function are going to be a big part of it. So I'm very excited that there's hope on the horizon. Some of you who have macular degeneration may be coming in to see us, or other doctors who might be telling you about some of these trials. So a lot of these, just like we had to do trials for our vaccines for COVID, you have to do trials to tell whether or not these types of treatments work. And so participation by all of us in these trials, I think, is very important to help us try to bring these new treatments to hopefully stop that process of losing those light-sensitive cells. All right, so that's great that there's positive progress, hope for the future. What can we do until we have these new treatments? I'd like to take the last couple of minutes to talk about that. One is you want to reduce your risk for developing macular degeneration, or if you haven't gotten it already, or it progressing. And so that means understanding what are the risk factors for why someone develops macular degeneration. Well, age obviously is the biggest risk factor, but there's nothing any of us can do about that. We don't have a cure for aging so far. We also really can't do anything about gender. I mean, I mentioned that women are a bit more likely. These are not risk factors that we can do much about. We also can't do much about ethnicity. We do know that it's more common in lightly pigmented individuals. And similarly, if you have a lighter, eyes, like blue eyes, higher risk from than dark colored eyes in terms of development of macular degeneration. But again, nothing that we can do much about these things. But there are things that we can do something about. So we know that obesity, which obviously is a big problem in our country now, is relevant in terms of your risk. And losing weight and the like can certainly be associated with reducing your risk. Blood pressure also may be a factor. It's less consistent, but I think it makes sense to exercise, lose weight, keep your blood pressure controlled. They're good anyways, and so we should be doing them regardless of what your feelings are with regards to macular degeneration. The biggest risk factor that we know of, aside from things like age, is smoking. So smoking is bad for so many things, and it's bad for macular degeneration. And so it increases your risk of developing macular degeneration by about threefold, because in a way, smoking kind of prematurely ages our body. So it's not surprising this would be the case. Another question I commonly get is, what about sunlight? Is that making my macular degeneration worse? And there is some data to suggest that more sun exposure is associated with higher risk. And so I would strongly advise wearing sunglasses when you're out and about based on that. And of course, genetics makes a difference, right? You can have two people doing exactly the same thing, and one might develop macular degeneration, the other might not. And part of it is related to our genetics. And we have identified a number of genes that are relevant, but there's nothing really we can do about that at this stage. Diet makes a difference. High-fat diets are associated with a higher risk. Diets rich in antioxidants like green leafy vegetables, like spinach, kale, sea fish are seem to be associated with a decreased risk. So those are some things that you can do. And then also the question comes up about vitamins. And we do have one. The National Institutes of Health showed that this particular vitamin, this Preservision AREDS 2, could reduce your risk of progression of macular degeneration by 30%. Really only slows the progression to wet macular degeneration, but that's still important. 30% is not huge, but it's something. And I think that's something we can do, but it only is beneficial. It only reduces the risk by 30% in someone who already has a significant amount of macular degeneration, has a bunch of DRUSEN already present. So we're not advising that everybody over the age of 50 start on this, because it's not going to make a difference if your risk is really low. It has to be when you already have some amount of macular degeneration that it's worth taking this. I've also asked about other things like ginkgo biloba and bilberry and acupuncture, and I'm not saying they don't work. We just have no evidence that they do. So I don't generally tell people they can't do these things, but I also tell them that I have no idea if they're of benefit. So only the Preservision actually has data to support it. So that's something I want to emphasize. So what can you do to protect yourself until you have a cure? It's actually pretty simple. Don't smoke, healthy diet, like I've talked about, exercise, and then if you actually have some macular degeneration, the Preservision vitamins. So that is our strategy so far. But with all that exciting stuff that I mentioned that we're working on in the laboratory, and I also mentioned, sunglasses, control blood pressure, they're not as clear how beneficial they are, but I think they're reasonable things to do. So I advise them as well. Okay, and so also, another critical thing is that, it's very common, so we recommend an annual eye exam for everyone over the age of 50, especially critical for those who have a family history or have some of the risk factors like smoking and the like that we talked about. And once you're diagnosed with macular degeneration, your eye doctor will tell you how frequently you need to come back based on what he actually sees, or he or she actually sees in your eye. And then between the visits, we say use things like this grid test or other devices that one can use as well, where you cover one eye, check your vision. It's important to cover one eye because sometimes you can't tell something's going on because you're just looking at things with both eyes open. And so this is a nice way of picking things up early. I usually say try to do that once a week to pick up on changes. And what can you do if your vision has already been lost because of macular degeneration? This is what I'm going to finish with. The challenge is that the retina really is like brain tissue in the eye. It doesn't grow back on its own so far. We're working on maybe you can grow it back, but we can't so far. There are treatments like stem cells that are being investigated, but they're still very much under development. And so until these kinds of things, whether they're stem cells or retinal implants or even this really cool approach of trying to take the non-light sensitive cells and make them light sensitive, something called optogenetics, these are still a ways away. And until they're successful, our main focus is really vision rehabilitation. That's why I was so glad to be able to do this presentation for the Braille, because we rely on centers like the Braille to help us with their occupational therapy and giving us sort of tips and tricks on how to best utilize our vision, how to take advantage of assistive devices like magnifiers to help us overcome some of the limitations that we've lost the most light sensitive cells or the highest resolution areas in the very center. And there's going to be a lot more with wearable devices, I think, coming in the next year or two, taking advantage of augmented reality to help us better use the rest of the retina that we have left. And so I think that's a vital part right now of maximizing our vision. So I'll conclude so we can have some time for questions by highlighting just some summary points from this presentation. That AMD is a common problem. Mostly it'll be affecting people over the age of 50, especially over 65. Early detection, so when you just have DRUSEN, or at least the DRUSEN of a certain size, as I mentioned, and using those vitamins at that point, I think is very important. Diet, exercise, and not smoking are also very important, as we highlighted. We know that wet macular degeneration can develop, but it can be controlled with eye injections. That at least is something we can manage. And there are a whole host of different treatments under investigation. We don't have one to cure atrophy or prevent progression of atrophy yet, but there's a lot of progress there, and I think that I'm very optimistic that we'll have that in the near future. Until then, low vision assessment and vision rehab at centers like Braille, I think, are vitally important, and so we're very fortunate to have them. And so I thank you very much. I will stop there. I hope that was of some help, and I'm delighted to take questions.
Thank you, Dr. Sadda, for such a wonderful presentation, the updates, and oh my God, the details that you included in your presentation, the videos. It's something so new for us. At this point, I want to introduce our educational programs manager at the LA Center, Gabriel Harlan, who is going to do us the honor to host the question part of this presentation. So take it away, Gabriel.
All right, thanks, Rocio. And thanks again to Dr. Sadda for such a great presentation. It's really surprising sometimes how much we can learn in just about a half an hour or a little more. Please use the raise hands feature in Teams in order to indicate that you want to ask a question of the doctor. And it looks like some of you are already doing that. We're going to try to keep our questions short and take about 10 minutes for questions and answers. And I'll take these in the order that everyone raises their hand. So first we have Lori Patterson with our first question.
I just wanted to say thank you so much for making this available to us, and will it be available on the website?
Thank you, Lori. Yeah, this presentation has been recorded. Rocio, do you have any details about how this might be shared on the website? Or
Yes, it's actually going to go on our YouTube channel. So if you haven't subscribed, I highly suggest that you subscribe to our YouTube channel, and you should get a notification when it's uploaded. So it should take about maybe a couple of days to upload it.
Okay.
Thank you very much.
Perfect. Thank you, Lori, and thank you, Rocio. Let's see. Our next question is coming from Dave Holt.
Yes, doctor, the question I have is there a relationship between cataract surgery and the advancement of AMD? In other words, does it get worse faster if you have cataract surgery?
It's such a great question. Thank you for asking that. And actually, there were some initial studies that suggested that maybe that was the case because we were seeing that there's more macular degeneration after cataract surgery. But later, it turned out that part of that was because when the cataract is there, it's hard for the doctor to see in and make the diagnosis. Once the cataract comes out, we can see very clearly, and we were able to make the diagnosis. And so some subsequent studies that have looked at this by getting appropriate pictures before and after cataract surgery were able to confirm that there does not appear to be an increased risk from cataract surgery. So we don't suggest delaying cataract surgery for fear of making the macular degeneration worse.
Great. Thanks, Dave, for that question, and thanks for the clarification, Dr. Sadda. And our next question is coming from Carmela Clark.
Yes, hi. My question is, can you explain atrophy again?
So atrophy refers to a loss of tissue or loss of cells. So when we use atrophy in the context of macular degeneration, we're talking about losing the light-sensitive cells. So as I was mentioning about the retina, it's a complex structure. It has layers of different cells. And one of the layers of cells are cells that when light goes into our eye, they absorb the light, and then they convert the light into electrical and chemical signals, which then travel back to our brain. And so you can imagine if those cells are gone, yes, light can keep coming into our eyes, but there's nothing to receive it and translate it into useful information. And so atrophy refers to the loss of those cells. And that's the big problem in macular degeneration.
Okay, thank you.
Great. While we're rolling right along, next question is coming from Barry.
Yeah, this is Barry Walters. It was my honor to actually have Dr. Sadda treat me beginning about 20 years ago. And I have been the beneficiary of all of the advancements that he talked about in his lecture. And the questions I had are every single question I had was answered by his presentation. So I thought it was wonderful. Thank you very much. And it is no question that I still have vision today because of Dr. Sadda.
Well, thank you for that. It's so nice to hear your voice. Thanks for joining.
That is awesome. That is awesome. Yeah, thank you, Barry, for sharing. And yeah, it's just great that the presentation was so accessible to a lay person like myself. You know, all these technicalities and Dr. Sadda's deep knowledge was just communicated to us in a very accessible way. It's great. Next question from Joy Motzko.
I have a 80-some-year-old aunt with a pretty severe case of dry. She's lost most of her central vision already. Is there anything she can do at home to just keep a check on herself to make sure it's not progressing to wet? Because of the COVID, she's not going out as much, not going to her doctors 3 times a year like she used to. Any suggestions?
Yeah, thank you for asking. I'm sorry to hear about the trouble that she's had. You know, it is a challenge. It is definitely harder to assess changes in your vision when you've already lost a lot of vision. And I think that's where, I mean, hopefully she's connected to a low vision, a center that specializes in low vision care like the Braille that can help her with assistive devices, because that would be important. So if she can maximize how she uses her vision, it may be easier for her to judge changes. So I have many patients who have significant atrophy, and you know, it is important because even if you have significant atrophy, you can unfortunately still lose more vision if you develop, for example, new blood vessels that bleed on one side, or just the atrophy is progressing in some way. And it'd be important to detect, especially if there's new blood vessels, if that's happening. And to judge that, I often say, you know, figure out some activity that you can do, right? So maybe because of the severity of the macular degeneration, you can't read comfortably anymore, but maybe you can still do some reading of larger print using an assistive device, and then use that and changes in that to help you monitor if something's happening with your vision. That's probably the best advice I can give, aside from obviously regular exams. And I totally get that with COVID, it's harder now. Hopefully that's going to get better in the next few months. But that's the best advice I can give right now.
Thank you.
Great. Thank you for that question, Joy. I'm going to take a couple more and wrap up question and answer around 10:58-ish before we do our raffle, so make sure you stick around for that. Next question is coming from, I believe it is Weizhou Li.
Yes. Thank you, Dr. Sa. My question is, retinitis pigmentosa is one of the macular degeneration, or they are totally two different diseases, and if one person can have both?
Wow. So first of all, they're definitely two different diseases. I hope that no one would have both, because that would be a very bad combination of problems to have. I'm not aware of. I'm not aware of anybody. I've never seen someone who's had both problems. Fortunately, it is a very different problem. Retinitis pigmentosa is an inherited retinal condition that initially affects your peripheral vision, your rods, your night vision, can unfortunately progress to the point of affecting your central vision and leading to blindness. In many ways, it's worse in the sense that with macular degeneration, as I said, and I'm talking specifically about age-related macular degeneration, because there are other conditions that can affect the macula alone as well. But with age-related macular degeneration, it does affect that most sensitive part, but it doesn't generally result in loss of peripheral vision. And so that's where you're able to get around, take care of yourself, and the like with macular degeneration. Whereas with retinitis pigmentosa, because it can affect the entire retina, starting with a peripheral retina, you can go completely blind from it. So two totally different conditions, and even our approach to how we do rehabilitation may differ quite a bit for the two conditions.
Great,
Thank you so much.
Good question, good answer. I'm going to take time for one more question before we move on. This question is from Deborah.
Hello? Are you hearing me?
Yes.
Oh, okay. I'm one of those persons that's getting a shot in the eye. Not painful at all, but I wanted to know if they told me it's because I had high cholesterol that affected my eye, and how much longer do I have to get these shots in my eye? I notice you have these other little things that are coming up. So should I inquire with them about something other than going to get a monthly shot?
Yeah. So it's from the problem you described, it sounded like it was something not macular degeneration, but maybe some kind of a blockage of a vessel, since you mentioned something about cholesterol.
Vein occlusion.
Yeah, vein occlusion. So that's a completely different problem, but it also is treated by these kinds of injections. So as I mentioned, these delivery devices, these like the port system, it's just the data has just come out now, so it's going to be a little bit of time before it's approved by the FDA. So yeah, you should definitely inquire about it from your doctor, but the answer is going to be, well, it's not available yet. But you might be a candidate for something like that when it becomes available. You have to kind of, there's going to be a whole complexity around deciding who it's going to be best used for and that type of thing. So I think that's something to hopefully come down in the near future, and then hopefully will spare you from having to get such frequent injections.
Yeah, just when they numb the eye, it's like it's burning sensation. But I'm going to get the vitamins. It's okay for me to get it? Sure, I check with the ophthalmologist I'm working with.
I think you should check with your ophthalmologist, because the vitamins really would only be of benefit if you actually have macular degeneration and actually have reasonable amount of those DRUSEN deposits that I mentioned. So there's really no evidence to suggest that they would help with a vein occlusion. So I would definitely check with your ophthalmologist before starting on them.
Okay, thank you.
Sure.
Could I just ask a question in regard to glare? I have wet macular degeneration that supposedly is stabilized by injections, but I have a tremendous problem with glare.
So glare is not typically a problem that one would expect specifically related to macular degeneration, but obviously, unfortunately, you can have more than one eye issue, and glare can arise from cataracts. It can arise from after cataract surgery. Sometimes there can be a clouding of a membrane that they leave behind that they set the lens implant on. That can also produce glare. But there are other things that can affect your cornea that can produce glare. So I would advise checking with your ophthalmologist to actually define what the cause of the glare is, because glare is typically not a symptom of macular degeneration itself.
Thank you.
Great. Thank you, everyone, for the great questions. It's time to move on. Before I move on to the raffle, Rosia, would you like to have any word?
Yes, thank you, Gabriel. Final thoughts. Again, many thanks to Dr. Sadda for taking time out of your busy day to come and share this space with us. But also many thanks to Sharon Takayama and Cecilia Samudio, who is our main contact with the Doheny Eye Institute, and thanks to them, they make it possible for us to connect with our wonderful doctors and bring them on board so they can share their knowledge with our community. Also, I want to share that if you are not familiar with the Braille Institute and by luck you just happen to learn about this presentation today, I recommend you visit our website for more information at our services, our library services, orientation and mobility, low vision consultations, independent living skills classes, support groups. You will find a lot of information there that it may be beneficial to you, to a loved one, a friend, someone in your community. Do share this. At the end, after the raffle, we will share information about upcoming workshops that are coming up. If you don't know this, February is Low Vision Month. So Braille Institute has made it a big effort to honor this month. We have a big campaign. We still have, I believe, another week left in the month. So we have 2 more coming up. On February 25th, we have a workshop on stem cell research to treat sight loss. So that I promise it's going to be a wonderful one. And then on the 26th, to close our month, we have one that a lot of clients usually ask, is a guide dog the right thing for me? So make sure you check out our website, sign up for them. If you want a free low vision consultation, visit our website. As Jennifer Liam mentioned, there is a form there. You could also call us at 1-800-BRAILE, and that will be 1-800-272-4553 to